It is my pleasure to introduce our presenters. Connie McCallum is a nurse practitioner at the Niagara Health Stroke Prevention Clinic, and Lisa Franzi is a clinical nurse specialist at the Hamilton Health Sciences Stroke Prevention Clinic. Together, they have been working in the field of stroke for over 20 years. They are very much committed to providing high-quality, patient-centered care. When they're not at work, you can find them enjoying delicious food and traveling to their next destination. And with that, I'll turn it over to Connie and Lisa.
Thank you, Tina. Thanks so much for that very kind and accurate introduction. Hi, everyone. I'm Connie, and this is my good friend and colleague, Lisa Franzi. And we just wanted to say thanks so much for taking time out of your busy day to join us for this next hour. We're going to be guiding you through this presentation on secondary stroke prevention, simple strategies to reduce stroke risk. Objectives for today are identify risk factors for stroke, identify strategies to address risk factors with the goal of reducing risk of recurrent stroke, utilize education resources available to support teaching on secondary stroke prevention. Now, keep in mind that our focus here today is on secondary stroke prevention, which is individually based clinical approach aimed at reducing risk of a recurrent vascular event in individuals who've already experienced a stroke or TIA. Primary prevention strategies will not be discussed today. Our secondary prevention recommendations are directed to those risk factors shown to reduce vascular events. They include attention to lifestyle and management of medical conditions such as hypertension, elevated lipids, and so on. In this next slide, we see the continuum of stroke care. Lisa and I are both immersed in the secondary prevention component. Our touch point with patients along the continuum is in the secondary stroke prevention area. However, we want you to be aware that secondary stroke prevention strategies really should be implemented throughout the recovery phase, including in the inpatient rehab, outpatient rehab, reintegration into the community, and onward, and including following up with the primary care practitioners. So as we go forward through this presentation, we invite you, all of you, to think about where you are at in your role in this continuum and how you will incorporate our strategies that we're going to discuss today into your own practice as you provide quality care for your patients. So we are going to talk about our risk factors, and they are the four main risk factors that we have today that we'll be focusing on: hypertension, tobacco use, hyperlipidemia, and diabetes. Hypertension and tobacco use are going to be our number one and number two risk factors today. They're the ones that we want to focus on, as hypertension is our number one risk factor for stroke. Numerous population-based studies have actually found that elevated blood pressure is a significant risk factor for first and recurrent strokes. Hypertension is estimated to account for about 60% of the population attributable risk for cerebrovascular disease. And the significant impact of smoking on stroke is only second to hypertension. We have our list of risk factors, and when we're looking at the complete list, we have our categories of modifiable and non-modifiable risk factors. As you can see in the slide right now, we have our modifiable risk factors. Our four main risk factors are listed on the left. And along with that, on the right-hand side, there are many other risk factors that we can make a change in and reduce our risk of developing vascular disease. And these factors are the risk factors that we can control. We'll be getting into each one of these along the way. And they are listed as activity, nutrition, alcohol, recreational drug use, medication, and weight. Our non-modifiable risk factors are age. Of course, risk increases as you age. Gender, with respect to that, it's women after menopause have a higher risk than before menopause. Family history, if you have a parent or sibling who has had a stroke, heart attack, or diabetes, you are at increased risk. Ethnicity, adults of Aboriginal, African, or South Asian descent are at greater risk. And although we can't change these risk factors, patients can make healthy lifestyle changes that can reduce the risk. For instance, if patients have a family history of heart disease or diabetes, we want to have that conversation with them, and they would have that conversation with their doctors to make sure that they're having regular blood work and making lifestyle changes to reduce the risk. We wanted to mention these risk factors, however, they will not be discussed further on into this presentation. So this is an important slide, and Lisa loves this slide. We both love this slide, actually. We want to keep in mind, before we delve into the risk factors and the guidelines, that our health depends on many things, okay? What we eat, the medications we take, all of these health behaviors are influenced by a multitude of factors, including food insecurity, income, housing, etc. So any promotion strategies would need to address the social factors. This can be challenging, of course, considering the time and resource that we have. And we need to take the time to understand these underpinnings and individualize our approach to secondary stroke prevention. Secondary stroke prevention is not at all a cookie cutter approach. Each patient situation is different. Our approach should be different and flexible and individual for each patient. And a few things to keep in mind when we're with our patients. Understanding the patient's current state and practices to ensure education is relevant and targeted. We have to have an individualized approach looking through the lens of the social determinants of health. Of course, we should always remember to ask permission when we're offering education to our patients. Our messaging about risk reduction education to the patients should be also individualized. And one of the most important parts of this is team approach, okay? Engaging with experts along the continuum. Lisa and I do this every day. We not only talk to each other and other care providers in the Central South Stroke Network, we are constantly on the phone with our partners in outpatient rehab or public health. They're important parts of the team as well.
Okay, so our first poll question, hopefully everyone can see that. So what is the #1 risk factor for stroke? Is it hypertension, diabetes, tobacco use, or elevated lipids? Hopefully the poll works.
Yeah, we're getting lots of responses.
Okay.
Okay, I'm going to end the poll now.
Great.
And
oh, amazing.
Wonderful.
Yes, hypertension, #1 risk factor for stroke. And Connie's going to do a deep dive into that right now.
Okay, great. So with hypertension, among persons aged 55 and older with normal blood pressure, 90% will develop hypertension if they live to an average age. Elevated blood pressure is a significant risk factor for first and recurrent stroke, and it's estimated to account for about 60% of population attributable risk for cerebrovascular disease. And several trials have actually shown that about a 28% risk reduction in recurrent stroke in patients treated with blood pressure lowering medication. So that's quite significant. Here is important target information for when looking at hypertension. Most patients should have a target of less than 140/90. People with diabetes and intracranial hemorrhage, their target should be less than 130/80. In order to help with prevention and management of hypertension, these are some of the things that we can be assisting our patients with as well. Okay, care providers have opportunity to improve awareness and management of blood pressure and equip people who are experiencing a stroke with knowledge of measurement of their blood pressure, tracking and recording tools, and whatever they need to mitigate their future risk. When we're talking to patients about monitoring their blood pressure, proper technique is important. It does matter. And we have the website hypertension.ca for those of you who wish. It's an excellent resource for both healthcare providers and the public on how to record and report blood pressure. We've included that here for you today, just a list on how to check blood pressure at home. This is information that's important to pass on to your patient in order for them to provide the appropriate numbers when they come into the clinic. So good things to note when they are checking their blood pressure at home, when to check it: before taking medication, at least 2 hours after a meal, after emptying bowel and bladder, 1 hour after drinking coffee or smoking, 30 minutes after exercise, and always after resting 5 minutes without talking. And ways to measure, how to measure. Make sure that they're in a comfortable, distraction-free environment. Sometimes can be difficult when they're in a house full of people. But without talking or moving is important. Sitting in a supported position, so back supported up against a chair, legs uncrossed with feet flat on the floor. A bare arm, always important. I can't tell you how many times I've tried to put a blood pressure cuff on a patient and they say, oh, I've been to the doctor's or I've been to another appointment and they just take it over my coat. Don't do that. So ensure the arm is bare. Use your non-dominant arm unless told otherwise, with a lower edge of the cuff 3 centimeters above the elbow. Arm supported with middle of the cuff at heart level, and you can rest that arm on the table in front of you. That hypertension.ca website has a list of recommended devices for you to share with your patients, or you can guide them to that website. Lisa and I thought it would be a good idea to provide a checklist after each section today to leave with you so that you it can direct your care with the patient. Okay, so we have a checklist that says we want to review what high blood pressure is and how it can affect their health, review the link between high blood pressure and stroke, discuss benefits of maintaining high blood pressure within the range, provide patients with resources on high blood pressure if they're interested, reviewing blood pressure targets with the patient, that's a very important component, advising them to have regular blood pressure checks at home with their family doctor and community, and then reviewing proper technique, of course. And this is one that I tell my patients on a regular basis. Advise them to bring their home blood pressure monitor to their family physician's office, general practitioner's office, yearly to ensure accuracy of the device. And you can always provide the patient with a list of recommended monitors or direct them to the website.
Okay, so next poll question: target blood pressure for patients with diabetes and intracerebral hemorrhage is less than 140/90, less than 130/80, or less than 120/80.
Okay, I'm going to end the poll now.
Great. Yes, the right answer, less than 130/80. So for those patients who want their blood pressure just a tad bit lower. Yeah, that's great.
Good. Want to try this one?
We're just sticking, just hold on there. Okay, so the next section is tobacco use. And Connie mentioned this already at the beginning of her talk, that the significant impact of smoking on stroke is second only to hypertension. So we really like to focus on hypertension and tobacco use in the stroke clinic, and we hope that you'll do the same regardless of where you're working in the continuum. So we know that 45,000 plus Canadians die each year from smoking. Tobacco kills 50% of its users, and it's the leading cause of preventable death and disease. And as clinicians working along the stroke continuum, we see firsthand the devastating impact of stroke where tobacco use is a significant contributing factor. The Quality of Stroke Care in Canada stroke audit found that among Canadians who experienced a stroke, just over 40% were current smokers, right? So, and it's also estimated that globally, just over 20% of the stroke burden is attributable to tobacco use. So that's the bad news, but the good news is that after 5 to 15 years of quitting, the risk of stroke is reduced to that of someone who has never smoked. So when it comes to secondary prevention of stroke, tobacco cessation is critical. So I can't talk about tobacco cessation without mentioning the tobacco industry. And I hope this lights a fire in you like it does in me. And if you're interested in more information on this topic, maybe reach out to Tina and we can do a more in-depth session. So I want to talk about this because why do people start smoking? And I often hear from healthcare providers that patients choose to smoke. It's their problem. They're doing this to themselves and it's not our place to intervene. And we really need to start placing blame where blame is due, and that is not on the individual, but rather on the tobacco industry. They have strategically marketed tobacco products to children. Cherry flavored cigarillos, come on, right? Those are targeting kids. They've targeted women and other vulnerable groups for decades. And this really lays the foundation of how we approach people who use tobacco products. The tobacco industry has long denied previous knowledge of the addictive nature and harmful effects of tobacco products. They've deceived us. They've deceived policymakers about the harms of tobacco. They've manipulated science. They've used third parties or phantom organizations to promote their agenda and interfered with public policy processes. What's even worse, you may be surprised to hear this, in an attempt to promote a positive image and legitimize their activities and products, they have continued to participate in corporate social responsibility programs, supporting a wide range of causes and organizations, including hospitals. So beware. More recently, they have been behind the e-cigarette or vaping movement, doing what they've always done. So when it comes to tobacco use, we need a bold approach, much bolder than the marketing strategies that are fed to us by big tobacco. Now, really, this bold approach is actually quite simple on the part of healthcare providers, and we're going to get into that shortly. So our bold approach is really low effort and high impact. So we talked about the health impact of tobacco use, what gets people hooked, right? We are marketed by the tobacco industry, and but why do people continue to smoke? We know that tobacco use is complex. It's driven by multiple components: physical addiction, psychological addiction, social factors. Nicotine is actually one of the most highly addictive substances known, more addictive than cocaine or heroin. When you inhale nicotine from a cigarette, the nicotine reaches your brain within 7 to 10 seconds. It's quite a remarkable delivery system. The nicotine binds to your nicotinic receptors in the brain, causes the release of dopamine, which then causes feelings of pleasure and calmness. So inhaling delivers that nicotine hit that makes smoking so addictive. The brain is actually altered as a result of tobacco use. You get upregulation of these nicotinic receptors, which then increases the demand for nicotine over time. Nicotine actually metabolizes quickly, so it clears quickly from the brain, and there's that continuous need for redosing. So having said all that, you can only imagine, yes, addiction to nicotine is one of the hardest substance use dependencies to break. Now, keep in mind that nicotine is the addictive chemical in tobacco. However, it's actually quite safe. It's the 4,000 other chemicals in tobacco that are the chemicals that result in cardiovascular disease, such as stroke, as well as cancers and other diseases. So what we want to do is treat tobacco dependence for the medical problem that it is. And knowing what we know about the impact of tobacco use, as healthcare professionals, we have an ethical responsibility to address this with our patients. So the guidelines are clear, and this is level A evidence. We need to identify and document patient tobacco use status, provide non-judgmental and specific advice about the importance of tobacco cessation. We need to do what we can to support a quit attempt, especially when patients are in hospital managing their nicotine withdrawal. and referring to resources that are available to us. And I'll get into that shortly. Now, one of the things I often hear from healthcare providers is the number one reason that they think patients don't want to quit is their motivation to quit. So they tell us that, yeah, patients are really not motivated to quit, so why bother intervening? This is some research that was done just next door to us in Waterloo. We know that the majority of tobacco users in Canada are motivated to quit smoking. In fact, 65% have thought about quitting in the next 6 months, and 30% are ready to quit in the next 30 days. So in order to help these people become successful in their quit attempt, they need to be supported by us, healthcare providers, at every interaction. They also to keep in mind is that patients expect to be asked about their smoking status when they're in hospital. So it's not going to be a surprise to them when you ask that question. The other thing I think that's really important to bring up is, we know patients expect to be asked, but we also know that not offering support can actually be harmful to patients. So sometimes what we'll say is, do you use tobacco products? Yes, I do. And then the next question is often, are you interested or ready to quit? And if they say no, we often stop there. But the research tells us that smokers who are not ready to quit actually quit at the same rate as those who are ready to quit. So proactively offering these individuals support is beneficial for people who are ready and who are not ready. And if we don't support these patients who are not ready, we miss treating a large population of patients. So what is this bold, low effort, high impact approach? We call it the 3 A's. You might also hear it called minimal contact intervention. It's 3 A's in less than 3 minutes. And we know that if every healthcare professional spends 1 to 3 minutes at every visit, and we're talking every point of contact in the system with each patient, the proportion of people who smoke would decrease by 2% each year, which is huge in the world of addictions. Even more powerful, advising your patient to quit smoking and offering support. So taking that next step has been shown to increase quit attempt rates by 40 to 60%. That's huge. So what does this look like? The approach is actually quite simple. I think for those who might be a bit nervous to go down this path, come spend a day with us in the clinic. I'm happy to have you. We do this all the time, and I think the patient's reaction to you is always the best feedback for you and how you approach this with patients. So practice different approaches, see what works, but we keep it pretty simple. So have you used any form of tobacco in the past 30 days? What type of tobacco are you using? How much do you use per day? And then providing that personalized, non-judgmental advice on the importance of tobacco cessation. So this is one example. You have a patient who's admitted, you might want to say to them, the best advice I can give you is to quit. Quitting can significantly reduce your risk of having another stroke. While you're admitted, you won't be able to use tobacco the same way that you do at home. So we can work together to manage your withdrawal symptoms while you're in hospital. This gives the patient an opportunity to start thinking about quitting, connect the dots between smoking and stroke, and also try nicotine replacement therapy while they're admitted. So that's just one example how you might approach it with your patient. If the patient says, no, absolutely not, I am not interested, I don't even want to talk about this, then okay, that's fine. It sounds like you're not ready to quit right now, and that's okay. I want you to know that I'm here anytime you want to call me. If you change your mind, know that you can get support in the community. There are places I can refer you to for free pharmacotherapy, or you might say patch gum inhaler, however you want to phrase it. So again, that ACT piece is important. We're supporting them. We're keeping that door open, even if they may not be ready to quit. And again, there's a lot of written material out there. I'm going to go through a couple of things today, and if I miss it, please reach out to me after this session. I can give you whatever you need to support your patients. So in terms of what's available to support patients, okay, just briefly, medications, they're huge. So we know that nicotine replacement therapy used in combination is super effective. So not just the patch, but also combining it with the fast-acting products as well. Patients are 3 times more likely to quit using combination therapy compared to cold turkey. Similar results for Champix, also a really great oral medication for patients who are interested in quitting smoking. Community support is also key. So here in the stroke clinic, we have nurses that will follow up with patients, provide counseling over the phone. We're also lucky that we have a public health unit. They will take the baton and follow up with these patients as well in the community. But there are, as I mentioned before, there are a lot of supports available that you might not be aware of. So I can't go through all of them today, but please reach out to me after and we can definitely hook you up with that list. Okay, so this is a checklist of things that you may want to go over with your patients. Now, this is pretty in-depth because in our stroke clinic, we're dispensing NRT, so you may want to pare this down. Again, you're advising patients the benefits of quitting. For those maybe working more intimately, maybe, working with NRT or different pharmacotherapy options, discussing how the products work, discussing harm reduction strategies. This is also critical. So, the end goal is quitting smoking, but with any addiction, we want to meet patients where they're at. So maybe their goal right now is to reduce by half. Maybe their goal is not to smoke in the house, not to smoke in the car, and that's excellent. We want to support patients with all of those harm reduction strategies. Discuss barriers or triggers to smoking, discussing strategies to manage withdrawal, discussing how to manage slips. I had a patient in yesterday, he's been still at 4 to 6 cigarettes for a few months now. He's had a couple of slips. He's increased a little bit here and there, and we just discussed it's part of the process. It's okay. It's normal to slip. It's normal to relapse. That's how quitting smoking works. So how can we support you to move forward? All right, so poll question here. Oops. Sorry, Tina. Advising your patient to quit smoking and offering support has been shown to increase quit attempt rates by 10 to 30%, 20 to 30%, or 40 to 60%.
Okay, I'm going to stop the poll.
Yes, amazing.
job.
40 to 60%. So again, please advise your patients, arrange for support, and if you don't know what that looks like, reach out to me. I'll give you a nice handout and you can go over that with your patients. All right.
Excellent.
Passing the baton.
Good job. Good job.
You can tell I'm passionate
Oh
about
my
this.
goodness, yes. We divided this one up correctly. Okay, on to the next risk factor is lipids, and we know that high cholesterol is associated with a higher risk of vascular events, including stroke. So, yes. So lipid management for patients with ischemic stroke or TIA include lifestyle and medication. Lifestyle, food choices plus exercise, of course. And food choices, we want to get them to focus on increasing their intake of their soluble fiber. That's always a good piece of advice for patients trying to lower their lipid profile. Exercise, also important. Statin therapy, medications that help lower the LDL levels. We want their LDL target to be less than 1.8, okay? And if the LDL happens to be still greater than 1.8, we would consider adding ezetimibe, 10 milligrams in addition to their statin. Sometimes some patients just, we can't get that LDL level to where it needs to be. In those patients, may consider adding a PCSK9 inhibitor. Unfortunately, expensive and injections. So, easier to take medication if you can by mouth. So the other component of this is triglycerides. So triglycerides, if greater or equal to 1.5 to 5.6, and a patient with atherosclerotic cardiovascular disease, and they're receiving maximally tolerated statin dose, then we can consider something called icosapent ethyl, 2,000 milligrams BID. The thing I want to say about the triglycerides, though, if I have a patient come in and their triglycerides are high, I always look at their numbers. I always look to see if they've fasted for that blood work. If they haven't fasted for that blood work, their triglycerides may be a little bit higher than if they did do a fasting blood work. So I would like to see another lab value. I would also have a discussion with the patient on their food choices. So things like alcohol and sugary foods and sugary drinks do elevate the triglycerides. So before I would consider something like additional medication that may not be covered, may be expensive, I would recheck their triglycerides after having a conversation about some of the things that they're taking in. So alcohol, sugary foods, sugary drinks. And then I would like to see also what their hemoglobin A1C is as well, to make sure that if that's elevated, that can also increase the triglyceride levels. Okay, so people who've already had an ischemic stroke or transient ischemic attack will benefit from cholesterol lowering medications, statin drug, for sure. 16 to 30% relative risk reduction has been reported in recurrent vascular events in patients with a history of stroke who are treated with a statin agent. Our checklist for lipids, we want to review the lipid targets. Lipid LDL target should be less than 1.8, HDL less than, greater than 1.3. Triglycerides, the value is less than 1.7 or less than 1.5 for diabetics. We want to discuss benefits of lipid management with our patients, proper use of lipid-lowering agents, lifestyle changes to improve their lipid values, and encourage them, especially to follow up with their primary care provider to complete their lipid panels to ensure that their targets are achieved. And you want to, anytime there's a change in medication, I would repeat blood work in about 3 months' time.
Okay, so poll question. What is the target LDL for patients who have had a TIA or ischemic stroke? Is it less than 1.5, less than 1.8, or less than 2.0?
Okay, there's still a few people responding, but I'm going to end the poll now.
Okay,
Yeah.
so kind of close here. So
Yeah.
yeah, target is actually less than 1.8. Yeah. Great. For the poll question, there's a bit of a delay,
Yeah,
so just hang in there with me. Okay, so diabetes is the next risk factor. So we know that diabetes is a major risk factor for cardiovascular disease, and it's recognized as an independent risk factor for ischemic stroke. So the risk of stroke is 50% higher in persons with diabetes. Oops. So managing diabetes. So the key here is, of course, screening. So doing that hemoglobin A1C. For patients who have diabetes, we want to make sure that they're tested every 3 months. The target hemoglobin A1C, which as many of you know is the average blood sugar over a 3-month period, we want that to be less than 7%. Just keep in mind though, for frail elderly populations, you want to refer to the current Diabetes Canada guidelines for target A1C levels. I was on their website recently. There's a really cool calculator that you can use to determine a patient's A1C target. So I'd recommend heading over to the diabetes website, Diabetes Canada website, to check that out. Lifestyle obviously is very important. So food, exercise, sleep, stress, managing stress. Pharmacotherapy. So as many of you know, medications to manage diabetes have really exploded over the last few decades. It's hard to keep up with them actually. And this is why it's so important to make sure that patients are getting the support that they need to manage their diabetes by their primary care provider, but also through the Diabetes Education Center. Our centers have excellent dietitians and nurses who are there to provide our patients with support regarding lifestyle, so diet, exercise, blood sugar management. And also under medical directive, they can also add or make changes to their pharmacotherapy. So it's a wonderful support. I highly recommend referring patients if they're interested in that sort of support. Also keeping in mind, medication needs will change over time because diabetes is progressive. That's why it's so important to make sure that their A1C is being checked every 3 months. So if we notice a creep and they're doing everything they can in terms of lifestyle, they may need a medication adjustment. Same thing goes for hypertension as well that Connie was discussing, right? So your blood pressure might be okay today, but over time your needs might change. One of the things I do want to mention is, I sometimes hear these sorts of things, or this might be sort of underlying with healthcare providers, is that, regardless really of what kind of diabetes patients have. I just want to make sure that we message to patients that it's not their fault. Some people feel like, oh, I've been eating a lot of sugary foods and so on, but that alone is likely not to cause diabetes. There's other factors going on there. So, it's not their fault. How can we support them to move forward? And the other piece here, we'll talk about food shortly, but also, people who have diabetes can eat all types of food. All foods fit. And that's where the dietitian comes into place too. It's how are we combining these foods together to get the best blood sugar management. So, are you adding protein? Are you adding vegetables to your meal when you're having that piece of dessert? So that will give you better blood sugar control throughout the day. So I wanted to just mention that as well. And then in terms of the checklist with your patients, so discussing the benefits of maintaining blood glucose levels within range, discussing that target hemoglobin A1C of less than 7% or whatever it may be for that particular patient, advising the patient that they would need to have regular foot care, eye exams with their primary care and primary care provider visits, advising the patient to follow up with their primary care provider to complete their blood work, providing education resources, and referring to their local diabetes education program. So, poll question.
Oh, sorry.
It's okay. What strategies are effective in diabetes management? Is it lifestyle changes, pharmacotherapy, support from diabetes experts, or all of the above? Oh,
Yay.
wonderful. Love to see it. Yep, all of the above. That's great.
Okay. Excellent. So on to activity, another modifiable risk factor. When I have conversations with patients about activity, I always want to make sure when we have this conversation, if they're at any risk for fall or injury, or if they have any other conditions such as heart disease, we want to make sure that they speak to their physician before starting an exercise program. The guidelines say an accumulation of about 150 minutes of moderate to vigorous exercise or activity per week is the guideline. It can be broken down into increments, and as long as they're in episodes of 10 minutes or more, it counts. So I always tell people, choose something that you enjoy, something that you think you're going to be able to do. Everything counts. So checklist for patients, what are they currently doing for exercise? First question I ask, right? And then we discuss the benefits of physical activity, which effectively lowers blood pressure. We recommend an accumulation of 30 to 60 minutes of dynamic exercise, moderate intensity, walking, cycling, swimming, whatever they enjoy, okay? So sometimes we think walking is the easy thing to do, but not for a lot of people. They might prefer cycling or swimming. So just whatever they enjoy is fine. 4 to 7 days per week. And this is in addition to their routine activities of daily living. They always like to count, mowing the lawn or something as their, activity. And that's wonderful. Excellent. I'm glad that you're active. Maybe we can incorporate something else too. So always support, right? Avoid sitting for long periods of time. Something I like to tell patients, if they do sit and watch TV for long periods, I encourage them to get up if they're watching something with commercials and not just streaming. Watch something with commercials, get up and walk around during the commercials and go back and then sit down for the TV show. And then discuss barriers and strategies to setting and maintaining exercise goals.
So poll question, how many minutes of exercise is recommended per week? Is it 30 minutes, 60 minutes, 100 minutes, or 150 minutes?
Okay, I'm going to end the poll.
Okay,
Wonderful.
yes. Yep, 150 minutes a week. Perfect. Okay, medications is next. And medication management, we know, is a critical component to secondary stroke prevention. So there are a number of medications that you'll see patients on. One of the most common one is antithrombotic. So under that umbrella, you're going to find antiplatelet agents. So for patients, and I'm speaking mostly for patients here with TIA and ischemic stroke, patients will be usually on an antiplatelet, so that's aspirin or Plavix. If they have atrial fibrillation, they will be on an anticoagulant typically. Connie already discussed statin medications. We talked also about antihypertensives. Patients may be on one antihypertensive agent. They may be on multiple antihypertensive agents, right? So again, it's important to message to patients that we're going to have to tweak their medication until they're down to target. A lot of patients will tell us they don't want to be on medications, but we do remind them that being on these medications will help to prevent another stroke from happening, which means hopefully maybe less medications down the road. So, and also messaging to patients that these medications are lifelong because they sometimes think they're temporary. I mean, some medications are temporary, but for the most part, they're going to be on these medications lifelong. Diabetes medications we talked about, and smoking cessation medications we talked about as well. So some of the things that we want to go over with our patients is, is the patient taking their medications as prescribed? So if they come in, we see this all the time. Their blood pressure is not a target, their lipids are not a target, but are they even taking their medications? One of the questions we ask patients to try to tease out if they're forgetting and they're not taking their medications is, on average in 1 week, how many times would you forget to take your medications? And by asking the question in this manner, we're normalizing forgetting. So we're more likely to get patients to tell us, you know what, actually, yeah, I'm not taking my medication at bedtime. I often forget it. So we get into reasons for forgetting, and then we can work with them to come up with strategies that might work for them so they don't miss their medications. So it's important to be asking those questions, getting a lay of the land, and then working with them to look at those strategies. One of the things I think it's important to mention is like patient education around medication is so important. We often see patients who stop taking their medications after their 3-month supply is up. So, they might have been prescribed something on discharge, maybe let's say a statin, 30-day supply, and then they just stopped taking it because they didn't think that they were supposed to continue on or get a refill. So this is why it's so important to use strategies such as teach back. So you're telling the patient about their medication, how long they have to be on it, what it's for, and then getting them to repeat that back to you and then clarifying any questions from there. All right, let's go to the poll question. Okay, so when assessing if patients are taking medications as prescribed, what's the most effective statement to obtain the most accurate response? Is it, are you taking your medications? Do you ever forget to take your medications? Or on average in 1 week, how many times do you forget to take your medications?
Okay, I'm going to end the poll now.
Right. So on average in 1 week, how many times do you forget to take your medication? Again, that normalizes forgetting medications. You're more likely to get a more, fulsome response from the patient. Great. All right. So next hot topic here is nutrition. Hold on a second. Just after the poll question, there's a bit of a delay with getting the slide over. Okay, so the guidelines clearly state that we should be counseling and educating our patients regarding healthy eating patterns that focus on whole, natural, minimally processed foods instead of specific nutrients such as dietary cholesterol. So typically we recommend the Mediterranean or the DASH diet. And, this is not, I don't think this is going to be a surprise to anyone. We know that these types of diet patterns are high in vegetables, fruits, whole grains, healthy fats, and low in meat. So, we often focus on the Mediterranean diet. The best evidence actually for the reduction of stroke events is the Mediterranean diet, and this is based on the PREDIMED study, which evaluated the benefits of 2 types of Mediterranean diets compared to a control group in which participants were told to follow a low-fat diet. After a median of 4.8 years, the 2 types of Mediterranean diets were associated with 30% reductions in the primary outcome of MI, stroke, or death from cardiovascular causes. And so the core foods in this type of diet plan would be, again, whole grains, fruits, vegetables, beans, herbs, spices, nuts, healthy fats. So again, not anything surprising here. how do we message this to our patients? And I find, and I mean, I guess you'll find your own way of doing things. I personally find the easiest way to message this to our patients is really just following the plate method, keeping it super, super simple, unless of course they have specific, medical conditions that require a different dietary pattern. Our message is, as often as you can, make half of your plate vegetables and fruit, a quarter of your plate whole grains or carbohydrates, and a quarter of your plate protein. I often ask patients, tell me what you think a protein is. Give me some examples of protein. You'll often find that when they start giving you examples, they don't really know what protein is. So just again, having those conversations with patients, making sure they understand. Also want to flag here that when it comes to fruits and vegetables, especially for vegetables, canned is fine. Rinse them off, you'll get rid of most of the sodium. Frozen is also great. Actually, if they pick vegetables when they're at their peak, freeze them, excellent choice. Patients will often say to me, well, I don't really like vegetables, but I do like this one vegetable. And the answer is eat whatever you like. You don't have to eat things you don't like. Food is meant to be enjoyed, okay? So we don't want to force people to do things that, are not going to give them any pleasure. Salt is a huge contributing factor, sodium, as many of you know. So to prevent hypertension and reduce blood pressure in patients with hypertension, we want to reduce their sodium intake to no more than 2,000 milligrams. That's about a teaspoon of sodium per day. And most of the sodium that Canadians consume, about 77%, actually comes from processed foods sold in stores or fast food. If patients are making all of their meals from home and they're adding some salt when they're cooking, that's fine, right? So if they're adding a little bit of salt when they're cooking, that's fine. The biggest issue here is, they're eating a lot of processed foods, they're eating a lot of pickled foods, takeout, then they're adding salt. I mean, we're now going over they're basically getting a week's worth of their sodium allowance in one day. The research tells us that reducing sodium in foods would abolish high blood pressure for almost 1 in 3 Canadians. So amazing, right? So, and lowering sodium consumption to these adequate intake levels could reduce the incidence of stroke and heart disease by as much as 30%. So again, I mean, I'm giving a very brief overview right now, but we can get into a bit more depth with your patients. So again, we talked about rinsing your canned goods, like rinsing your vegetables and so on, getting rid of, and canned beans as well, getting rid of a lot of the sodium, comparing labels. So we have patients, right, who can't cook for themselves and they're eating canned or processed food. That's okay. So how do we choose better options? So the key here is pattern over plate. So how are you eating most days? What's your pattern of eating? That's what you want to focus on. If I'm going out for dinner tonight and I'm having, an indulgent meal with some dessert, it's not the end of the world. They're not going to have a stroke from having a piece of cake and enjoying their meal, right? So are they eating like this every day? Okay, that could be a problem, right? But again, the odd, indulgent meal is not a big deal. All foods fit, including processed foods, right? So this might be a bit controversial, but I really believe we need to stop demonizing processed foods. They can actually be more affordable, shelf stable. They have added vitamins and minerals that we otherwise wouldn't get. So keeping in mind that nutrition is not one size fits all. Health is not 100% in the control of the individual. So, again, if you're working with patients where food security is an issue, income's an issue, how can we find a way to get what they need, maybe even using processed food? And that's okay. Watching portion size, again, that's why we talk about the plate method. Focusing on adding nutrient-dense foods as instead of taking things away. So, okay, this is what you're eating right now. How do you feel about maybe adding X, Y, and Z? Eating more plants as often as you can, that's huge. Fiber, fiber, fiber. We're pretty passionate about fiber here for so many reasons. Better blood sugar control, lowering your LDL cholesterol, lowering your blood pressure, providing that feeling of fullness. Sodium, again, asking those questions, are they eating a lot of processed food and so on? Are their meals homemade? And then targeting your advice, setting small achievable goals. And then last but not least, balanced meals and snacking. This is especially important for patients with prediabetes and diabetes. So making sure that they have that source of protein and vegetables and carbohydrate with all of their meals, and all of their snacks should always contain a source of protein. So if you're having an apple, you're going to pair it with some nuts or a small piece of cheese or some yogurt, things like that. Again, this is a very brief overview. If there's interest in more information around diet or nutrition, reach out to Tina and we can maybe have a dietitian do a session. Okay, so some things we want to talk about with our patients, discussing the impact of nutrition on blood pressure, we talked really about all this already. Balanced eating vegetables and fruit every day, whole grains, adding those protein-rich foods. We often talk about avoiding soft drinks and juice, drinking water instead. And then there's the sodium piece as well. So, poll question. All right. So when referencing the plate method to patients, what proportions do we recommend? Is it half vegetables, a quarter protein, a quarter carbohydrate? Or is it a quarter vegetable, half protein, a quarter carbohydrate, a quarter vegetable, quarter protein, or half carbohydrate?
Okay, I'm going to end the poll now.
Oh, wonderful.
Yay.
Yay, wonderful.
Good.
Good job, everyone.
Yeah. So our next risk factor, alcohol. Okay, so now with alcohol, I'd just like to say alcohol will elevate blood pressure, okay? And it can also elevate your heart rate, and especially too much at one time, which can affect atrial fibrillation, right? So the key is reduce alcohol intake. If you do not drink, do not start. I can't tell you how many people have said, maybe I should try drinking a glass of red wine every day. And that's not something they would normally do. No, if you don't drink, don't start. The guideline is do not exceed 2 standard drinks per week. And a standard drink measurement, that's the important part. It doesn't matter the type of alcohol, it's the amount that is key here. The standard drinks are measured as listed. A beer, a 12-ounce bottle of beer is equivalent to a 5-ounce glass of wine is equivalent to 1.5 ounces of spirits. That's all listed here for you. Our checklist for alcohol and advising patients of the impact of alcohol use on blood pressure. Reduce alcohol intake. If you do not drink, do not start. And do not exceed 2 standard drinks per week. And ensure that you review their standard drink sizes with patients. They're often shocked at the measurement of a glass of wine, you know.
Okay, so number of standard drinks. So individuals should not exceed this many standard drinks per week. Is it 1, 2, 3, or 4?
Okay, I'm going to end the poll and share the results.
Yes. I don't know who put 4, but that's okay. That's a common response we get actually from patients because, and the reason why I said that is because the guidelines just changed.
Yeah.
And it's actually very confusing. So it used to actually be like really, really high. What was it,
10 a week for women and 15 for men.
Yeah.
Yeah.
So 4 would have been somewhere in the middle there.
Yeah.
Yeah. So it has changed.
Right.
And it's a surprise to us and to patients. So
yeah,
again, just highlighting that. Okay. So that's great, everyone. Thank you. Now we have 2 minutes. I'm just gonna having trouble with the slide here just a second here. Last but not least is education materials. Okay. Oops. Really jumped ahead there. All right. So education materials, I listed a couple websites here that we commonly go to or recommend our patients go to. You know, some patients are into looking at websites. I think the whole piece here about patient education is what works for the patient.
Right.
Do they want websites? Do they want written material? Do they want to meet with a nurse or someone one-on-one? You know, asking them what works for them, and then reaching out to your resources, as Connie mentioned before. Are there people like in the stroke clinic that you can reach out to? Can you provide me with some information? I'm not expecting, if you're a PT working in outpatient rehab, I wouldn't expect that you have all these resources at your fingertips. Reach out to the stroke clinic nurse in your area. We have loads of handouts, patient education material that we can provide you with that's very targeted. One of the things that I want to highlight is we just recently updated 2 patient education resources. One is called Your Guide to a Stroke and TIA, focuses mostly on ischemic stroke and TIA. It's a very comprehensive booklet that we give to patients. It goes over everything pretty much we talked about today and much more. And also we recently launched an ICH resource as well. That's also in booklet format. We also have loads of other booklets, carotid stenosis, dissection. I mean, the list goes on and on. So the key message here is connect with your local stroke prevention clinic nurse. Give us a call. We're more than happy to help you. And before we wrap up, one of the things that we often tell patients, because a lot of anxiety around having another stroke. So we often tell patients, your risk is never zero. However, you're taking your medication, you're working towards quitting smoking, or you quit smoking, your blood pressure is where it needs to be, or we're getting you there.
Yeah.
You're doing everything you can, we're meeting with them, we're working through things. If you're doing all of those things, your risk is significantly reduced and you're doing everything you can.
Right.
And I think that does give patients some ease because, it's never zero, but
Right.
we can definitely get the risk down.
Right. Agreed. Yeah. The word prevention implies that nothing will ever happen again, right? But we want to just call it a risk reduction strategy. That's why we named it that. So we want to encourage patients to lower their risk as much as possible. And if they're doing their best, that's all they can do,
Okay, so we have maybe 3 minutes for questions.
Yes, thank you very much, Connie and Lisa. We have a couple of questions in the Q&A, so I'll start with the first one from Sue. Is there any research results on vaping and its effect on causing a stroke?
That's a really good question. So there is some research that says vaping can increase the risk of stroke. A lot of that could be from the combustion process because you're inhaling it. So the problem is vaping and e-cigarettes are not regulated. So it's very, very difficult to have these concrete studies looking at the risk associated with vaping, but we do know there can be negative outcomes. Connie and I were just at a conference on smoking, and they did talk about, the risk of increasing vascular events with vaping. So this is why we consider vaping and e-cigarettes the same as tobacco. I just saw a patient yesterday, e-cigarette user, and I started her on nicotine replacement therapy. So the approach with these patients is the same. I don't know if that answers your question completely. I'm happy to also provide whoever asked that question with a bit more information, some websites we have on vaping that gives a bit more bulk. So please reach out to me if you want more information. The bottom line is it's considered a tobacco product.
Okay, thank you. Hope has a question. Do you ever recommend dietary supplements, for example, omega-3 capsules for lipid management? We have had several patients who did not tolerate a statin and stopped themselves at home or have consulted their family physician for alternative options.
So in terms of omega-3, I mean, what you're going to notice with omega-3 intake really is a decrease in your triglycerides. It doesn't typically make a difference with your LDL. Having said that, even about triglycerides, there's no evidence that supports a reduction in stroke events using supplements. So no, we don't recommend them. If they really can't tolerate it, I don't know what region you're in. I mean, here in Hamilton, even if you're outside of Hamilton, you can request to get a referral to the lipid clinic. And if patients meet criteria, they can have a lot of those injectable medications covered. But no, we don't recommend. And then again, I mean, they may need a referral to a dietitian to look at how can we boost up, like maximize dietary interventions, like boosting up soluble fiber and so on to get their LDL as low as we can.
Okay. Sue did say thank you for your response, for the vaping response, and she also expects that research will be coming as time passes. Sue also is wondering that she thought the new guideline for alcohol was 1 drink per week.
Let me look it up. Wow, this is good. I like this. Okay, so.
Okay, maybe while you're looking it up, there's a question from Shannon.
Look at the next one. I'm going to look it up.
How does alcohol increase blood pressure?
Physiologically, I'm not sure. Connie, do you want to take that one? I'm looking up the guidelines.
Yeah, no, that's okay. So alcohol, you know what? Alcohol taken immediately does help to relax at first, but over time, and especially too much at one time, is like a constriction of the vessels, and then the blood pressure becomes higher. And especially too much at one time. The effects of the alcohol is long-term in the system. and can affect blood pressure as well as heart rate, and get the heart rate right out of whack with respect to atrial fibrillation as well.
Okay.
And I'm reviewing the guidelines for alcohol. I feel
yeah.
like at some point there was some mention that they're not totally sure how it's physiologically. I'm not sure. Increases blood pressure. We
Oh.
can review the guidelines
Okay,
too.
sorry.
I'm not sure, but yeah, that's pretty
Yeah.
much like
Yeah.
I'm not sure if you're asking the physiological part of it.
Okay.
But anyways, I just want to go back quickly and get back to this one. I just reviewed the Canadian Center on Substance Use Addiction. It says so 0 drinks per week is what we recommend, but 2 standard drinks or less per week is the recommendation. Not the recommendation, but you want to basically be under that. So
2 or less.
2 or less. Now, that's what I have here, and that's what we've been following. However, we'll clarify again to make sure. I need to look at this in a bit more detail. So thanks for the question, and stay posted.
Okay, it is 12:01. There are a couple of questions that we didn't get to, but I'll take note of them and then I can share them with you. And I want to thank you very, very much, and got some comments about this having been an excellent presentation. I just want to let everyone know that there is the feedback link also in the chat, but as they close the webinar, there'll be the option of clicking on a very short evaluation that is really helpful for us to know. Tomorrow, all the participants will receive an email with the recording and the presentation slides. And just another reminder, we have our next Stroke 101 on March 21st, and Dr. Telig will be presenting an approach to post-stroke fatigue. So have a great afternoon, everyone, and see you soon. Thanks.